So we've been asked today to present some of our work in prostate cancer, and like in all things we do these days, it cannot be done by one person and certainly should not be done by one person. And I'm very fortunate in Cambridge to work with some fabulous people who have worked together collaboratively as a Translational Prostate Cancer Group to actually deliver what we think will be transformative in terms of prostate cancer care in Cambridge and going forward as well. And with me today is myself. We've got Dr. Warren, our pathologist, Dr. Barrett, a radiologist, Charlie Massey, one of our scientists and bioinformaticians, Dr. Pacey, our oncologist, and David Thurtle is one of my MD students. What I'm going to show you today is the results of work we're doing in real time. This is not esoteric, this is not sometime in the future, this is actually what we're doing now. And the reason that's important is because we need to change how we manage prostate cancer quite significantly and quite quickly. Now, you will know, I'm sure, that prostate cancer is one of the most common prostate cancers in the UK and internationally. And the figures are quite stark, actually, because from the National Prostate Cancer Audit, we've got 41,000 diagnosed in 2016, and the projections are that the number is going to rise by nearly 69%. If you look at these pie charts of cancers diagnosed in 2007 and 2030, you may not be able to see the detail, but what I can tell you, that only 2 cancers are showing a higher incidence than this date, and that is prostate and melanoma. The East of England happens to have the highest incidence rate of prostate cancer in the UK, or in England anyway. Now, the Translational Prostate Cancer Group here is focused primarily on first diagnosis, first presenting prostate cancers. And that represents 85% of all our patients. Most of the research that's done in the UK and elsewhere is focused on men with metastatic and castrate-refractory disease, which clearly has a higher mortality, but represents quite a small proportion of the patients we see. If you like, our ethos is to get it right first time, and that is what our efforts are about. Now, there is a problem in prostate cancer management, and that is that while we may have 41,000 or 47,000 diagnoses and 11,000 deaths a year, it actually only represents 7% of all deaths. And if you can see this bubble here, that's the peak rate of prostate cancer death, and that age in there is 90, which means you have to be fit enough to die of prostate cancer, by and large. So, lots of incidents, not many people dying, and if they do, they tend to be of a higher age. So the lifetime incidence is 13%, the risk of death is 4%. So men who die of the disease actually usually present very late, and those who do present early, very few will actually die of it. So prostate cancer represents not so much a problem for its lethality, but for its diversity in its presentation and how we manage it. And this is very important because we now have RCT data which has shown that if you randomize first diagnosis patients to surgery or radiotherapy or surveillance, you get absolutely no difference in survival at 10 years. And this is from the National PROTECT study in the UK and also mirrored in the US in the PIVOT trial, where between observation and surgery, there really wasn't much difference in terms of the distribution. So we have a paradigm where actually a lot of patients are being overtreated for prostate cancer, primarily because we are using pretty outdated methods of assigning risk or prognosis. So a few years ago, we published this piece of work, and what this shows is the NICE criteria, still endorsed in 2018, which divides men into the low, intermediate, and risk and high risk categories, and you decide on treatment based on that. And we tested this in our population cohorts, up to 86,000 men, and actually it's only about 67 to 69% accurate. And by the simple expediency of reclassifying patients using the Cambridge prognostic group system, we were able to identify much better who would actually die of the disease. And this is a group of patients that we will come to later on who are of particular interest, who are doing very badly despite radical therapies. So, the Translational Prostate Cancer Group was formed about 5 years ago, and since then I think we've been moderately successful in terms of grant income and lots of papers. We have a fabulous team of fabulous individuals who I have the pleasure of working with, and of course state-of-the-art diagnostics and therapeutics and regional network links as well. It is underpinned by our research office with a great team of people, and also our ethics and biobank, which allows us to do a lot of very fantastic work around genomics, around biomarkers, and clinical annotation. We incorporate imaging and biopsies and trials, all in one repository in ethics, which I can't really expand on, but it underpins some of the work that you're going to see today. So, critical questions. We do a lot of things, but perhaps the 3 relevant for this meeting today is how do we change the paradigm of overtreatment and personalize the decisional value of a treatment? Meaning to say, if you're diagnosed with a prostate cancer, how do we work out whether you really need to be treated or not? How do you improve the poor outcomes in primary aggressive disease despite radical therapy? And how do we make sure that whatever we do in terms of research actually translates in a rapid way to practice? Because a lot of research gets done, lots of papers get published, it never changes anything. Key to this is being able to produce tools and devices which anyone can use. So let's illustrate that by looking at two cases today, which is what the CPC is about. So this first case is a 61-year-old gentleman, quite fit and well, no comorbidity, ASA1. Father had prostate cancer, but there's really no genetic history here. PSA is 7.3, the normal range is 0 to 3. He had a normal prostate examination, and he was referred to a prostate diagnostic clinic as a 2-week referral. Now, we've been fortunate in incorporating some very cutting-edge and state-of-the-art imaging and diagnostic methods, which are already in routine use here, and we take advantage of that. So in our prostate diagnostic clinic, what happens is you get a raised PSA abnormal DRE. According to this algorithm, you will then have an MRI scan, which allows us to see where we're going. Because previously, trying to take a prostate biopsy was like going to this potato and trying to find a worm. It's quite a tricky thing to do, and often you don't get it. But with MRI, we are able to visualize, and of course, for me, it still looks like gray blobs. I'm going to pass over to an expert who's going to tell us about what this particular individual's MRI, Dr. Tristan Barrett.
Thanks, Vincent. Tristan Barrett from Radiology. So this is some selected sequences from an MRI study on this patient. So overall, we produce about 3,000 images from a prostate MR. So I'm only showing you 4. Actually, the video that's playing is an amalgamation of about 700 images. But just to kind of give a summary of what we do. The video in the top corner is the dynamic contrast enhanced MRI, so you can see that on the loop. You can see the contrast washing into the prostate, washing out. Another thing to note on that is if you look underneath, the rectum here is spasming quite a lot during this study. And that's a 6-minute sequence. The other sequence we do are about 5 minutes, so you can see how motion can really affect some of the quality of the imaging we do. Ideally, we don't have rectal distension if there's no fecal loading. We do advise the patients that they empty the bowels the day of the study, but it doesn't always work, particularly if they're being scanned at 7:30 at night. And we give buscopan to try and reduce the rectal spasm as much as we can. So in terms of the sequences we do, the anatomical imaging is the T2 weighted image up here. Then we use 2 functional sequences. The dynamic contrast enhanced MRI, giving contrast and washing it, seeing it wash in and wash out, is one of those functional sequences, and diffusion weighted imaging is the other of those sequences. And we get a B-value map where we're looking for things being very bright, and then calculated from multiple V-values, we get a sense of how the diffusion, how the water molecules are moving around, and we get a quantifiable ADC map. And on this, it's almost the inverse. Things should look black. The blacker they are, the more likely they are to be tumour. In terms of the anatomical imaging, we have the peripheral zone around the outside, which is nice high signal intensity on the T2 weighted imaging. And then in the centre, the transition zone where BPH typically occurs, very heterogeneous, lots of mixed signal intensity within it. The majority of tumours happen in the peripheral zone, around 70 to 75%. So it's rarer to get transition zone tumours, but obviously we still have to pay attention to that area as well. When we score these MRIs, so we have very little clinical information. We may have a PSA. We do in this case. Sometimes we don't even get that. We try to score out of 5 for probability of tumour. And sometimes the PSA can be explained by the gland volume. We can also measure the gland volume. In this case, the gland volume is 65 centimetres cubed. So that's compatible with a PSA level of around 6 or 7. The gland volume alone may explain that with the background BPH. But you can still have aggressive tumours with low PSA and relative to the PSA density. And so we still have to look for that. But that's an important piece of clinical information we use further down the line. We score everything out of 5 for these sequences. And DC, it's just a yes or no, positive or negative. And if we score a 1 or a 2, that's saying it's a negative MRI, so we don't think there's a tumour. It's usually quite predictive. There's a 90% chance there's not an aggressive tumour in there, and actually a 98% chance, depending where you draw that line, of it not being a tumour, aggressive tumour that needs treatment. If we score a 4 or a 5, there's quite a high probability that that area will have tumour, and that leads to a targeted biopsy. The slightly unfulfilling one is the one that's in between, the 3 out of 5, and that's what it is in this case. So we're in the peripheral zone here. When we're in the peripheral zone around the outside, diffusion is king, so that's the one we defer to. So that's scoring 3 out of 5, so that trumps this score of only 2 out of 5 on the anatomical imaging, and there's questionable early enhancement within that, but I'd argue it's not more than the background peripheral zone, so there's perhaps some inflammatory change in there, and we look at the colour map, you can see it's confirmed there's no early enhancement within that area, so it's negative on the DCE. So slightly unfulfilling case from our point of view, we have to sit on the fence, so we've called this area as a 7 times 3 millimetre area of PIRADS 3 indeterminate probability on MR, so not completely normal, but not looking like a very aggressive tumour to us on imaging.
Thank you, Tristan. So this has really revolutionized how we actually diagnose prostate cancer, not in just diagnostics, but actually, for as you will see later, in how we actually start to bring this to bear to improve our care. So with that MRI, for which we have a very high quality in the UK, we then go forward for prostate biopsy. And Cambridge is one of the first centres in the UK to incorporate image fusion biopsies, work led by one of my colleagues, Christoph Kastner. And we have this system which is in the outpatient department, which allows us to see where the lesions are and take a sample. Using this kind of technology with MRI imaging, we've been able to increase our cancer detection rates from about 40% in 2012 to about 70% recently. So now this chart goes on to have a biopsy, and we've got some samples, and it goes on to Dr. Warren, who's our long-suffering pathologist, who's now going to tell us about what we found.
So in terms of the histology and the biopsies, what we do is we basically screen a series of sections from each of the cores, and we're obviously looking for foci of cancer. So when we do find cancer, our summary report includes some key information to guide patient management. So we state how many cores contain tumour and how many of the total, and what the maximum tumour length is in millimetres within a single core. And those parameters give an indication of the tumour load within the prostate. And we also give a tumour grade, which is very important prognostic information and drives patient management. So as you will know, all tumours get graded in some way or other. I mean, the simplest sort of grading system is dividing the tumours into well, moderately and poorly differentiated to indicate their likely biological behaviour. For some tumours, and prostate is one, we have specific grading system. And I'll just run through that with you. So we currently use 2 grading systems in parallel for prostate cancer. So we devise a Gleason score. Now this is the Gleason grading system, which was first described in the 1960s and has been in widespread international use for over 30 years now. And we use a more recent prognostic grade group system, which was introduced in 2014. Now both are very similar. What we do is we look at the architectural growth pattern of the tumour to derive a grade. And this is quite unique to prostate cancer, because most tumours we actually take into account the cytological atypia of the tumour in the grading system. But prostate cancer, even the most aggressive forms, shows very little cytological atypia. So the grading is purely based upon the architectural growth pattern of the tumour. Now, and as I say, the 2 systems are similar. The Gleason grading system, we look at the growth patterns. So originally 5 different patterns were described, and because modification has been required over the years to the grading system, as our knowledge of the behaviour of these tumours has increased, we basically, of the original 5 patterns, we really only use patterns 3, 4 and 5 in our description. So the Gleason pattern 3 tumours, that's the best differentiated tumours, show individual glands, nicely separated and well-formed rounded glands. Pattern 4 is where you have gland fusion, so you still have gland formation present but not individual glands. You get fused masses and poorly formed gland structures. Gleason pattern 5 then is where you have little or no gland formation. You have these irregular, ragged masses of infiltrating tumour cells, individual tumour cells, infiltration, and areas of necrosis. So in order to derive a Gleason score, we look to see which is the most predominant pattern present, and then which is the second most predominant significant pattern. So if we have a lot of this pattern and a small amount of this, we would say the tumour is Gleason 3 plus 4 with a Gleason score of 7. If we have a lot of this and a small amount of this, it would be a 5 plus 4 Gleason score 9. Now, so you basically end up where you can have a range of scores between 6 and 10, because if you've only got one pattern present, such as the tumour being composed totally of well-formed glands, we would say it's 3 plus 3 equals 6, so you just double the number if you've only got one pattern present. Now, the prognostic grade group system is essentially really a modification of interpretation of the same thing, but it's more clinically relevant, if you like, in the way patients are managed today. So the tumours are divided into 5 grade groups, and these are the equivalent Gleason scores. And where this has the advantage is that instead of saying to a patient that has a good prognosis tumour, your tumour scores 6 out of 10, and that's good. In fact, you say to the patient, you have a grade group 1 tumour, which is obviously much easier to understand and appreciate. Similarly, these two groups of tumours would have the same Gleason score, so a Gleason score of 7, 3 plus 4 or 4 plus 3, but they're divided in the new system into grade group 2 and grade group 3, and that is because tumours where you have a predominance of pattern 4 will behave far worse than tumours with a predominant pattern 3, even though the Gleason score is the same. So as I say, we do both in parallel. So our first case today, 13 samples were taken, including a target site biopsy. Now the target site biopsy was benign here, but one of the cores in the sample contained a small focus of tumour, which was formed of closely packed but well-formed glands infiltrating between these benign glands. And this was called then Gleason 3 plus 3 equals 6, grade group 1, and was 2 millimetres in size, so a small amount of tumour present.
So with high-quality MRI, with high-quality pathology reporting, we were able to quite convincingly know what this gentleman's tumour characteristics are. And so he's a 61-year-old chap with a PSA of 7, he's got an organ-confined disease, he's grade group 1, the lowest risk type in terms of histology. But what's the recommended treatment for this chap? Well, at the moment, if you look at the EAU guidelines, it says you can have watchful waiting or keep an eye on it, surveillance, even more closer, keeping an eye on it, or you could have surgery, or you could have radiotherapy, or perhaps some of these these more unusual experimental treatments. But where the key point is that it's a bit ridiculous to do all this stuff and then say, well, you've got this, what would you like to have? Here's a list, choose from the menu. So, the work that we have been doing is to try and take some of this excellence in diagnostics and grading and actually put it into something we can actually practically use with informed choice. And that's the work which has led to this tool, which I'm going to ask David Thurtle to now come and talk to you about, called Predict Prostate, which those of you who work in breast cancer will know there's a similar one in breast. But David, would you like to come and show?
I'm David, one of the registrars in urology. As Vincent has said, lots of these men, particularly with lower risk disease, have a real decision dilemma with the potential comorbidity of significant treatment, such as prostatectomy or radiotherapy, balanced against the psychological impact and the risks of a cancer diagnosis. And the intention behind Predict Prostate is to really inform that decision-making process, to give them accurate, unbiased, standardised information that's as individualised to them as it can be. So we've developed this tool called Predict Prostate, which is effectively a multivariable prognostic model. It's developed from about 10,000 men previously diagnosed in the east of England, and then we validated the model in another 70,000 men from both Sweden and Singapore, and have demonstrated that the model works well within different cohorts. That algorithm, that multivariable model, has then been converted into this patient-facing website with help from the Winton Centre in town. So if we move straight on to our case and enter his details here, this is testing my memory slightly, but I think his PSA was 7, and he had T2 disease. So you add information about the patient themselves, including comorbidities and hospital admissions, and then the details that we know about their prostate cancer. So we know this was a grade group 1, as Dr. Warren was saying, and we know that we have biopsy information for this patient. He had 13 biopsies taken, of which only 1 was positive. So all of these parameters are entered into the model, and then the model provides estimates on what their outcomes might be initially if they were conservatively managed. So this first graph demonstrates the predicted estimates of survival over 10 and 15 years if they were conservatively managed. And you can see from this that the difference between survival with conservative management and survival if prostate cancer deaths were excluded completely is very small. There's only marginal gain there even if you were to cure prostate cancer completely. If we then apply the radical treatment effect, which is again derived from observational data, you can see there's a marginal gain for this particular gentleman, so a 2% increased survival over 15 years in this case. That information can be presented to men in a number of different ways to suit the user, to suit the clinician that's discussing with the patient, and also the patient themselves and their level of understanding. That can be with survival curves, with raw data, or just with simple text forms. Importantly, when presenting this information, we don't just present the positives, the survival benefits, we also present the potential harms of treatment. It's important that one's contextualised against the other. So here we present data actually from studies rather than individualised on the particular outcomes of impotence, incontinence and bowel dysfunction, which can be side effects to each of the 2 main treatment types. So going back to our particular case, he stands to gain perhaps about 2% benefit over 15 years if he was radically treated. We're not saying from this tool what should happen to that man. The important thing is that he is as fully informed as he can be to make his own decision, weighing up the important things in his own treatment. To say we're running a randomised trial on this tool at the moment to see what impact it's making to decision making, and it will be launched in the next week or so alongside a paper. So that's that.
So, in summary, this gentleman's case illustrates one which is very typical and very common of a low-risk prostate cancer picked up from optimal MRI, optimal diagnostics from histology, and now we have a tool to actually estimate what would happen if this chap was to choose treatment or not. Now, this may seem quite logical. The truth is, up and down the country and internationally, people don't use prediction models. They use clinician expertise. And clinician expertise is a wonderful thing because the clinician always feels he's right. Everyone else never disagrees with him, but it doesn't really matter because you're the one in the room. So the point is, using the research that we've got, we've been able to translate some of our state-of-the-art diagnostics into something we can use now, every day. The Predict tool, as David mentioned, is going to be launched in a couple of weeks' time, and that's going to be available for anyone, anywhere, and also to patients as well. Not to say that they're going to self-manage, but that they can ask questions about it in a more informed way. So that concludes our first case, which is of a low risk, if you like, prostate cancer. Our next case. So now we have another gentleman. This is a 65-year-old chap. He's got atrial fibrillation and hypertension. He has no family history. He's on a bunch of medication there, but his PSA this time is quite high. It's 22. He has an abnormal feeling prostate, and again he's been sent along to us. And the first thing he does is goes in as an MRI. Tristan, would you like to?
Thanks. So again, a similar setup to last time. The anatomical T2 weighted imaging, the DCE imaging here, which should play on a loop. So I'll just set that going. And you can see the contrast washing in and washing out. And then we've got the diffusion weighted imaging on the bottom. So when we see an abnormal image, it's very obvious to us what is abnormal. When you're starting out, you need to get orientated. But if you remember from the previous study, the peripheral zone around the outside here was this nice high signal intensity on the T2 weighted imaging. And it is at the lateral aspects of the gland here, but in the center here, it's very low signal intensity. So that's a sign of tumour on the T2 weighted imaging, and then when we go to the DWI, the diffusion imaging, high on the B-value imaging, and quite low signal intensity on the ADC. So that confirms that there's restricted diffusion in this area in the posterior peripheral zone. And actually, it's extending anteriorly into the transition zone. Again, difficult if you don't have the normal imprinted in your mind, but this area here is a more normal appearing area of transition zone. If you remember, I described it very mixed signal intensity. It's actually described in the sort of the handbook for radiology as being organized chaos. So the normal peripheral zone, the normal transition zone, is all this very mixed signal intensity. Whereas here you can see it's more homogeneously low signal intensity as it is within the peripheral zone at the back here. So marked restricted diffusion, large volume tumour, probably incorporating about 60% of the gland in total. This also shows early enhancement on the DCE. So if we look at our scoring system, it's 5 out of 5 for the anatomical imaging, 5 out of 5 for the diffusion weighted imaging, and it's positive on the DCE. So it's as positive as it can be on our scoring system. But the other side of that is staging. So we're doing the MR to get staging. So in particular, the T staging of the gland. So is the tumour confined within the gland, or is it starting to go out? So T3A disease is extracapsular extension. So there's some subtle irregularity around the back here, but the fact that there's such broad capsular contact over there, so more than 15 millimetres, in this case probably about 25 millimetres, there's almost certainly, even if you don't see it, early extracapsular extension. And there is some subtle irregularity as well. Then we can look at things in the other plane, and we can see, in this case, it's extending directly up the ejaculatory duct and into the seminal vesicles in the midline here. So that's another higher stage T3B disease, seminal vesicle invasion. T4, which is the highest, would be invading other organs such as the bladder or the rectum or the pelvic sidewall, which it isn't in this case. So the staging is T3B. We get that from the MRI as well. For the more distal staging, we've relied traditionally on bone scan and CT. They have their limitations, and these were negative. There are newer forms of imaging coming along in terms of whole body MRI and gallium PSMA PET imaging. And one of the things I think is interesting, is why I deliberately put the dates on here, is if you look at the time of the diagnostic MRI, there's another 2 weeks to the bone scan, there's another 2 weeks to the CT, and there's probably one clinic appointment here, one clinic appointment here. So this chap has had to come back for 2 separate clinic appointments, 2 separate additional imaging tests to finally get all his staging investigations in the bag. And if you remember, his PSA at presentation was 22. So one of the things we're looking to implement is doing a whole body MR up front in patients with a very high PSA of 20 or more. So actually they get all their staging investigations done in one go at baseline. Now there's a risk that some of them don't have cancer, and we've done extra imaging that we didn't need to do. It's only a 60-minute study rather than a 40-minute study, so it's 20 minutes of magnet time. If you add up all the pound signs together, the saving here and here is more or less equivalent, but importantly, you've done everything in one visit rather than having to come back for another 2, 3, 4 extra tests before we've got all the staging completed.
So this chap is looking like he's got a pretty aggressive tumour, and would you like to take us through his histology, please?
So in contrast to the previous gentleman, this time we had 16 biopsies, and all but 2 of those contained tumour, and all of the cores that were from the target sites were positive. And so they all showed a similar thing. At low power here, you can see that there is a tumour coursing through the core. When we look at slightly higher power, the predominant pattern in many areas was pattern 4, so you've still got glandular space formation, fused glands, and then Gleason pattern 5 was also present, so these infiltrating cells, ragged arrangement and no gland formation. So this was a 4 plus 5, Gleason score 9, and grade group 5.
So this represents a very different kettle of fish. So let's put it into our online calculator and see what happens now.
So these are just some slides we prepared earlier. And as you can see, this is far more prognostically significant cancer. So that the gap between survival with conservative management, which is the dark blue bars, and his survival excluding prostate cancer is is much larger. And therefore the potential gain from radical treatment is much more significant as well. Although we appreciate there's some uncertainty around that prediction, and that uncertainty is larger in this case because actually there's very few men with these types of characteristics in whom conservative management has been used previously. These men would all be treated radically traditionally. Again, there's different ways of presenting that information to a man, but ultimately the estimate from the tool is that about 18 and potentially more men, additional men, would be alive as a result of radical treatment with these characteristics.
Okay. So this chap here falls into a group now where we would consider that his outlook is going to be pretty poor. He's got a high PSA, he's got a T3B into seminal vesicles, he's a high-grade tumor, and the primary recommendation for treatment is androgen deprivation with radiotherapy. But you'll recall this graph that we had before, because this chap falls into what we would consider before predict CPG5. And this group are a clear outlier in terms of outcomes. This is an old category which was part of the high risk, which actually did quite well, which is why it was hard to work out how to treat these men, because people actually did quite well in the heterogeneous grouping. So this tool, this data now allows us to look and say, this is the group that's doing quite poorly, and can we improve the outcomes by looking at the tumor biology? And of course, this audience here, this center here, is no stranger to this. Cambridge is one of the leading lights in genomic medicine, and breast cancer specialists are well and truly on the way and chilling back there. But we are trying to play catch-up. So what we have done is we have introduced a pilot, a personalized medicine pilot, to try and see whether or not we can actually start to do some tumor biology work to help us to improve the outcomes by informing clinical trials. And this is something which we've just introduced recently. It's the PMP project. You will recall, you've seen all the imaging, you've seen all the tools we have and the great expertise that allows us to target our samples. And one of the problems, as alluded to by Kurosh, is previously, how do you know about heterogeneity? How do you know about sampling and all the rest of it? Well, you can't, because unless you take the prostate out, which is not what you do for most men. But what you can do is go for the most obvious target lesion, and at that point take a frozen sample. Unlike breast, where you take the lump out, then you do everything else, in prostate that is not what happens. So for the first time, we can actually do the characterization with the in situ prostate gland. We get those frozen samples, we send them off to Charlie here, who's going to come up and talk to us in a minute about some work on circulating markers. We do some genetic profiling. At the moment, our budgets are tight. Cake sales haven't been going so well. So we are using the CMDL panel, which is the 350 cancer gene panel. But we have had a couple of these now where we bring together the team you see with you here to discuss, first of all, these issues. Can you integrate imaging, histology, genomics, and prognostics in real time for clinical application? So a practical thing. Can you find a reasonable rate of mutations and profiles and suitability for trials? And really to work out whether this kind of pathway is something we could start to do on a routine basis to help us. Now I have to mention Anne Georgia, who's in the audience, who's been our project manager, and it's because of her efforts that this has worked, and in fact the turnaround time is under 30 days, which is actually very realistic for real-time practice. Simon Pacey is with us today and has been running some neoadjuvant trials, so we have a pathway to trial delivery. But let's see what happens with this chart in terms of what we find. Charlie, would you care to explain this? Charlie is one of our bioinformaticians and basic scientists who's been instrumental in putting this together, and we're very fortunate to have him join our multidisciplinary team. Thanks.
So in this high-risk, high-grade tumour, the target lesion, we performed, as Vincent said, targeted gene panel sequencing, 350 genes using the GCPL ISO-accredited labs as part of the Cambridge Cancer Centre Integrative Cancer Medicine Programme at the Cambridge Molecular Diagnostics Lab. And what we found in this case was evidence of a very high mutation rate. So in prostate cancer generally, it's a very low rate of point mutations, single nucleotide variants, around 1 per megabase. And inferring from the size of this gene panel, we expect this to be around 10 times higher than the average prostate cancer. So this high-risk, high-grade tumour has a very high mutational burden. In terms of specific mutations, we find evidence of deleterious mutations in known driver genes in prostate cancer, including FOXA1, that I'll talk about in detail in a few minutes in the next slide, rather. And I guess the kind of headlines to take from this pilot offline study is that we can identify patients who have potential candidates or leads for therapeutic trials and therapeutic coordination with the oncology team to look at which treatments we might use in a kind of basket trial study, which Simon will talk about next. And in this case, given the very high mutation rate, as in other cancers, this may make this patient suitable for immunotherapy, and also suggests that there's an underlying DNA damage repair deficiency. So in particular, the driver mutation in FOXA1 in this patient occurs in a hotspot of driver mutations in prostate cancer, and these mutations are affecting FOXA1, which is a pioneer factor for the androgen receptors. It's required for genomic binding of the androgen receptor after ligand activation, and it occurs at the same site as other mutations that have been reported in the catalogue of somatic mutations in cancer, giving us confidence that this is a bona fide driver mutation in prostate cancer. In terms of the likely functional consequences of this driver mutation in this patient, there's a lot of data and not much certainty around the clinical implications of FOXA1 mutations. What's clear is that there's a modulating effect on androgen receptor signaling. So again, in this recent review by Jason Carroll, who's based in Cambridge, working on estrogen receptor in FOXA1 and androgen receptor in FOXA1 in prostate cancer, we can see evidence of increased binding at some sites, mislocalization of the androgen receptor, so kind of activation of different molecular pathways, and also loss of binding at some sites as well. So overall, this gives us a tool within patients to start to understand the consequences of specific classes of mutations in genes like FOXA1 in terms of their likely impact on standard care therapy such as androgen deprivation therapy, and in particular in cases like this where they're likely to receive upfront ADT with radiotherapy. And just as a kind of footnote for this, there are companies in Cambridge which are developing therapeutics that would target this pathway, and this commonly recurrently mutated gene in prostate cancer may be a reasonable starting point for those. And so just as a summary of this, in this high-grade, high-volume disease, the patient received ADT and EBRT as this 15-year survival prediction from the PREDICT prostate model. And in terms of what the molecular profile has added, in terms of things that we could do today, I would say nothing. But in terms of things that we can look to build on for the future, and bringing alterations which are actionable in late-stage metastatic prostate cancer into earlier disease, where we may have a bigger impact and an impact on outcomes more in a larger way, then the high mutation burden may help us to recruit patients who may be more suitable, particularly where they have high-risk disease, for immuno-oncology agents, and these FOXA1 mutations allow us to measure the impact on androgen receptor deprivation therapies.
So now we pass on to our oncologist. And this is the rare thing, because normally it's clinical oncology that works with prostate cancer, but we have roped in medical oncologists who's today represented by Henno, who's going to tell us what can we do with this data.
Thank you. My name's Henno. I'm one of the radiation oncology registrars, and what I will do is just talk to you about the treatment of advanced prostate cancer, so metastatic disease, and the recent developments in this sector, which are very exciting, and a little bit about the rationale for bringing treatment earlier and why we're so excited about using molecular testing at the time of diagnosis to potentially modify treatment. So prostate cancer has really seen a revolution over the last nearly 20 years. Up until 2004, we had very little treatment. We had androgen deprivation. We used estrogens, dexamethasone. That was pretty much it, with very little evidence and little efficacy. And then 2004, we had a working chemotherapy agent, and the first data came out for docetaxel. And over the last 10, 15 years, we've really seen a plethora of new treatments arriving in the metastatic space. We're now using drugs from lots of different classes. So we've got chemotherapy, docetaxel and cabazitaxel. We're using more advanced hormone manipulation in form of abiraterone and enzalutamide. We're using radiopharmaceuticals in the form of radium-223. We're using, not in Europe but in the US, immunotherapy in the form of Sipuleucel T, which is a dendritic cell vaccine. So this is the state where we were up until about 2014, and all of these treatments are very effective, but in terms of survival benefit, we get about 3 to 4 months of survival benefit, and especially in this space, we've got about a 30% response rate. So although all of these treatments do extend life, they're not spectacularly effective and not as effective as we'd like them to be. So what's happened over the last 3 or 4 years is that we've taken all of these agents that we know are effective and we've tried them up front. So usually the treatment pathway is we treat the clinically localized disease by radiation or surgery. In terms of radiation therapy, we use androgen deprivation therapy around this time. Once the patient then comes off the androgen deprivation therapy or their PSA starts rising post-surgery, we would go back onto androgen deprivation therapy, wait until the patient fails in this space, and then start any of these treatments. Over the last 3 or 4 years, what we've seen is, well, what happens if we move any of these treatments right to here? The PSA starts rising, we start androgen deprivation therapy, and we start docetaxel or abiraterone or a drug called apalutamide. And what we've seen is that these drugs are effective in this space, and they're a lot more effective than using them down the road. So docetaxel has about a 3 to 4 month survival benefit once you give it, once the PSA starts rising. If you give it straight at the diagnosis of metastatic disease, it gives a 12 months plus benefit. Exactly the same thing is true for abiraterone. So we know these effective agents used right up front, early in the disease, have a spectacular effect. Apalutamide is a direct anti-androgen, and a trial now published has shown that actually using it, not in metastatic disease, but in clinically localized inoperable disease, again, gives you about a 12-month survival benefit. So what are the new agents on the block, and what are the molecularly targeted agents? We've been using PARP inhibitors in ovarian cancer for quite a long time. There's a big phase 3 study here going on in breast cancer, and there's some evidence that PARP inhibitors, so these are inhibitors of DNA damage repair, are effective in prostate cancer. The TOPARP study from the Marsden has sequenced patients, so this is targeted treatment, for instance, for BRCA1 and 2 mutations, but also for other DNA damage repair mutations. And they found an 88% response rate, and this is post-chemotherapy. All of our other agents in this setting have about a 30% response rate. So molecularly targeted agents work in prostate cancer. We can also combine these agents with agents like abiraterone, which is a hormone manipulator, and again we get good response rates. And what Charlie alluded to is that if we've got high mutational burden in the cancer, then immunotherapy does work, although prostate cancer traditionally has been thought to be inert to the immune system. So how can we actually use this, and where are we seeing the molecularly targeted approach going? So what we need to look at is, can mutations in the androgen pathway, can mutational signatures guide us towards using drugs like abiraterone up front, or are there patients that we can identify that will benefit from docetaxel? At the moment, we could potentially use both abiraterone, a hormonal agent, or docetaxel in the early stage setting, but we need to tease out which patient's going to benefit most from which treatment. And then, can we identify patients that will really benefit from drugs such as PARP inhibitors? So can we identify patients with a DNA damage repair defect and give them PARP inhibitors up front, which we know work in the late stage setting, but following the logic of all of the previous treatments that we've seen, is this going to be much more effective if we give it potentially even at the time of surgery? Immunotherapy, can we use defects in the or can we use the tumor mutational burden to identify patients who would benefit from immunotherapy? And we knew from other tumor sites that that can be very effective, can lead to long-term tumor control.
Thank you very much. So, I will finish up there with this slide. And this is something which I put together some years ago as an aspiration, because this is where we were not very long ago. And it's actually been very surprising to me, and I think a testimony to what's capable in Cambridge, that we've actually done all of these things, more or less. Of course, a lot more work needs to be done, but we have pretty much got some pretty good imaging. We are starting to look at how we use genetic profiling and liquid biopsies. We have no time to talk about some of Charlie's excellent work here. We are personalizing prognostic prediction. We are certainly making biopsies safer. And ultimately, what we want to do is to see how this becomes part and routine of what we do every day. So a lot of this we can do already. Some we are testing out now. But ultimately, we want Cambridge to be the leading site for precision-tailored treatment, and it's not actually that far away. Thank you.